Hi, I'm Tim Wiedrich, and I'm Section Chief for the Health Resources and Response Section of the North Dakota Department of Health. And this is a statewide meeting of the critical access hospitals in North Dakota. I do want to remind you to go ahead and mute your microphone. I know that we do have someone that is not muted currently, and if you're not able to mute your microphone, we'll end up going into the system and muting your microphone, which will prevent you from participating in the rest of the meeting. So just make sure your microphones are on mute so that it doesn't interfere with the rest of the meeting. Well, I'd want to just start by saying this is a jointly sponsored meeting. It's being convened by the North Dakota Hospital Association, also the VP3 team with Human Services of the North Dakota State Government, and also the North Dakota State Health Department as well. I'm going to just quickly check in and see if Tim Blazell has any opening comments.
Good afternoon, everyone. Thanks for joining us today. Last week we had some discussion regarding bed capacity and how critical access hospitals in the state could help with that. And so that's the reason for the call today. So we have some objectives we'd like to meet. I'd like to review some of the challenges. And so, Tim, that's we can start there if you want to kick it off to me, or if you have a few other words you want to say.
Well, I did want to just quickly check in and get a greeting from the VP3 team as well with Human Services, just to be able to see and hear from them. So Roseanne, Seth, could you just say hello and any additional comments you may have?
This is Roseanne, and I'm with the VP3. And Seth and I are the two individuals that are going to take part in this call today. And I think to understand what our role is in the past, now it's been about 3 weeks, but over a year and a half, we've been part of the VP3 team that has assisted long-term care facilities and everything from the visitation guidance and just facilitating the testing process and understanding that whole thing. We also have been leading the six tertiary hospitals in a daily huddle call, which we did last year for about 3.5 months. And now we just started it for probably the last 3 weeks we've been doing it. So we'll talk a little bit more about that later, but that is the role that Seth and I as a VP3 play in this whole process.
And as I previously said, I'm Tim Wiedrich with the State Health Department, and I lead the section that has the Emergency Operations Center in it for the State Health Department, and coordinate the EMS system that's also within this same division, and health facilities in the same division, as well as the Emergency Preparedness Response section or divisions as well. So now, Tim, if we could just go to you and just kind of have you give us an overview of what some of the challenges that we've been facing with the increased hospitalizations that we've been seeing. And I do believe that Ellen from PCMH needs to mute their microphone. Go ahead, Tim.
Okay, thanks, Tim. So, I think we want to talk about, the challenges that are obviously facing the state. And as we all know, this is all related to capacity. So what I think we would like to talk about today really is the decompression of the tertiary care centers to provide additional higher level of care capacity. So again, what we'd like to do is take some of that pressure off the tertiaries because, as you know, in the tertiary hospitals, I think we have people that are in the ERs waiting for beds that maybe, if they don't need a critical bed or a specialized bed, could they be then transferred to the critical access hospital. So we want to talk about that today. So that would take some of that pressure off the tertiary hospitals. Now, we all know, another item we want to talk about is the pressure that all of you feel when you experience high patient volume. So we want to have some discussion regarding that. Could we, and maybe some of you are doing this, transfer patients from one CAH to another? And so we want to have that discussion. So I think those are the two critical challenges that I hear. Tim, I know you have something, I think you want to talk about EMS.
That's correct. So that in addition to the situations that Tim was talking about relative to the interfacility transfers, we know that the EMS system throughout the state is also under pressure as well. Those pressures are actually being seen across the entire state, large and small ambulance services. And so as part of that process, we are developing what I'm calling an EMS safety net, and I'll get into a little bit more detail with that information a little bit later in today's discussion. But as we move forward with today's discussion, let me once again just remind everyone to please check your microphone and make certain that you're on mute. So as we move forward with today's discussion, this is intended to be a discussion, and so we're going to present some high-level concepts to you and then look for your feedback as part of this process as we have the conversations that we're about to have. So let's just go ahead and Tim, did you have anything else with the description of the current challenges, or am I able to move to the next item?
No, Tim, I think I think we can move on.
All right. So in terms of the identification of, to get down into a little bit more context about what we're envisioning, let me first of all tell you what it is not. What we're envisioning in terms of this discussion, it's not to interfere with any process that's already going on between the tertiary care center and the coordination of critical access hospitals that may be part of those normal referral processes. And I think that will become evident a little bit later when we talk about the second call system as it's established within the state. And I know that there are some of the tertiary care centers that have or will be convening additional meetings with critical access hospitals that those affiliations exist with. And so that should continue on as normal. But we wanted to bring this group together as a community to talk beyond that level of coordination, because in the situations that we've seen since the last probably about 6 to 8 weeks or so, when we have needed to decompress facilities, it really has been more of a statewide process as opposed to just remaining within a given region. And so if in fact we are in a situation where the tertiary care centers, because of their normal catchment areas within the communities that they serve, have lower acuity patients within those facilities, by creating additional critical access hospital capacity, the idea would be that if needed, they could offload those patients to that level of care to free up higher acuity beds within the tertiary care centers. And that as part of that process then, to be able to build some additional surge capacity within the critical access hospitals. And then again, the second part of that would be when we have critical access hospitals that have more patients than what their comfort level supports, what their resources support, that we have a way without going from a critical access hospital to a tertiary care center, if appropriate, to do a lateral transfer to another critical access hospital so that we can, again, do a distribution of patients across the entire state. So as part of that process then, what we're envisioning is the second call system still continuing to function as it's designed. And again, just to touch bases about that, the second call system is operated by Essentia, and I'll go into, again, more detail about that towards the end of the discussion today. But it involves a critical access hospital making contact first with the PPS hospital, and if in fact there is no availability at that point, then to route the call to the second call system. And that system is then designed to look at the other tertiary care centers within the state. So that's the way that's currently functioning. This would go one step beyond that, so that we would have situational awareness for bed capacity across the entire state. And the way that process then works is that as the second call system completes its work, if in fact we've not located beds within that system, then they can reach back to the Department Operations Center, which normally functions in that capacity of locating beds when we haven't had COVID. And so we are coordinating with the second call system as part of that process. And it's at that level that we then send out the health alert message to find out what the status of bed availability is throughout the entire system and gather that information and then do the distribution from there. So as part of this process, we're really asking some questions of the critical access hospitals. And Clint, if you could go ahead and bring up my slides now. There are three main questions that are part of this. And the idea is that we're not looking at creating an additional sustainment of daily operations within the critical access hospitals, but rather really attempting to build surge capacity as part of that process. So that surge capacity is what we're asking about. And so the first question is, as a critical access hospital, are you willing to create hospital surge capacity for low acuity patients in your facility? And so that fundamentally is the first question that leads into the other questions. If the answer to that's yes, if you're saying, yep, count me in, we're willing to participate, that we are willing to build additional capacity over what our normal census is, but not to exceed what our licensed bed capacity is. We don't have any executive orders. We don't have any processes in place that we're anticipating that would require us to exceed any of the existing normal standards. But if the answer to that question is yes, then the second question is, how many patients would you provide care for? And so whatever that number would be something that you would need to work within your facility to identify a realistic number that you would be able to support. If your normal census is 4 and you have staffing resources to go up to 8, you might very well say, well, I could take on an additional 4 patients because my patient load really hasn't normally exceeded where I'm normally at, and you wouldn't require in that scenario any additional outside resource. But if you're in that same description, if in fact you could go higher, if you had some additional resource, then that's where the third question comes in, and that is, do you have any barriers, whether that's staffing, and that's what we're guessing the vast majority of people that are experiencing barriers will find those barriers. But if it's also equipment or supplies, if you do have barriers, then we would ask you to identify what you would need and how many of whatever item it is. If it's RNs, how many would you need? If it's other type of durable medical equipment, whatever it is, and then identify how many you would need. And so we're going to be asking that you provide that information to us through the Hospital Association, and in just an email textual form, just write up an email. And so you might want to please just make a couple of notes about these 3 questions, and that way you'll have the information at hand. And we're asking that you respond by Thursday, September 16th at noon, so that we can review the information and develop plans to move forward. Now, we do have certain quantities of additional staffing that are available within the state health department through our Department Operations Center. We're calling them the COVID response team. And so, to be really clear, these are RNs, nurses, CNAs, EMS providers, but all of our staff, and I'm especially focusing on the nurses now, these would be for low acuity patients. These are not ICU nurses. These would be for patients that would come from lower acuity settings like med surg. They could be long-term care. So there's that variety. We have some ED level experience. But again, we don't have ICU nurses that are part of this mix. So the role that we would be fulfilling in the staffing would be for low acuity patients. if in fact we can make those identifications and that we can act on the information that you're providing to us and make some decisions, we would then want to focus on being able to, for those facilities that are willing to take on additional patients, to take our resources and make some strategic application of those resources so we could build up some additional capacity within the system. So that, as a very high level, is the overview of what the intent of what we're attempting to do, to gather this information with these general concepts, and then to be able to use that information to begin to decompress the processes when we do have hospitals that are at capacity, and to be able to have some level of availability in other areas of the state, and to be able to accomplish that through interfacility transfers. I think before we open it up for discussion within this, I do want to ask Seth or Roseanne just to offer whatever additional comments that you may have. And if you could, it seems fitting to me at this point, not that we're going to develop any interfacility triage transfer categories today, but just generally speak about what our intention is to add some greater clarity about categorizing as we're doing these transfers. Seth or Roseanne?
Sure. This is Roseanne. So yeah, I can speak to that. And, and just to put it in context of why it even has come up as an issue this year. So last year when COVID, probably about middle of November, is when we started doing our hospital huddles, where we go through the census, looking at the COVID numbers, capacity, all of that on a daily basis. And we started that in mid-November, and we did it until I think it was the beginning of March. So quite a long time, 3.5 months or so. And during that time, everything looks a little bit different. And so that's probably, we've been doing now this year, only 3 weeks. We've only started it a little over 3 weeks ago. But there are some significant differences in what we see this year as compared to what we saw last year. And in particular, it's the number of ER holds that are occurring in the 6 tertiary hospitals and the number of deflections. So last year, there was a period of, 3.5 months, like I said, we only had 10 days where we actually had ER holds in our ERs in our 6 big hospitals. And as well as, we had very few days where we actually had even deflections. In fact, there was just when it was our peak COVID, which was in November, we had 1 week of where we had greater than 10 deflections 5 days in a row. This year already, our number of ER holds has ranged anywhere from 9 to 35, but mostly it's been running in the 30s every single day. And our number of deflections has been anywhere from 6 to 48 this year, but mostly that has been in the 30s. So what that says is then we have 30 patients that hospitals couldn't take from wherever the transfer request was. And we've really tried to hone it down to looking at our regular referral areas. So we're not looking at those that are coming in from Florida or Texas or Oklahoma or wherever else. We're just looking at those that are in our typical and regional referral area. So I think a couple of things that stand out. It's very concerning as a clinician, as a person that resides in the state and gets healthcare in the state, is when there are critical patients that are out in your facilities, for a distance away from the tertiary facility, and that hospital has no beds for any special, critical care beds or availability to take any of those transfers. So when you see that on a daily basis of, 30 plus, it's really, really concerning. So one of the things that, we've heard too is that, sometimes there might be patients in your critical access that you want to transfer out, you're looking to transfer to one of your regular, tertiary hospitals that you transfer to. However, there's no beds. And you may not, and maybe they aren't really needing a critical care bed or a specialty service, but you don't have the ability to care for them. They still need some type of hospital care, acute care, but maybe not at the level of a tertiary or, to transfer to one of those facilities. So a possibility might be that another critical access who has availability of beds and maybe the resources, staffing or whatever, could possibly take some of those and offload those and save the tertiary beds for those that really need a critical care bed or some specialty. So I think that's kind of where we started with this discussion. And it's been about a week of talking about how we can do, better at making sure that if patients really need a bed in one of the tertiary care facilities, that we're trying our very, very best to find a bed for them. And again, delay. That was the other thing that we really don't like to see is hours and hours of delay. And even an overnight stay when, you don't have all the resources to care for them. So really trying to get a handle on that and make that process better. That being said, there's one of the a couple of the facilities here are piloting with their regular referral critical access hospitals, trying to look at some process for triaging a little bit differently. So we don't have details surrounding that at this point because they're just trialing it right now. But that might be a possibility too of how we can look at, who needs to go where and who should have priority for some of these beds at the tertiary facilities. So that being said, that's kind of a high level overview of what it is that we're trying to accomplish. And again, if there's, questions that, you surely can call us or email us and we can, surely follow up with you. But again, it's at the point of where we're just working through those specifics and we will be reaching back to you if, we do have a process or a plan in mind of how we might make this work a little bit better. And that's all I have, Tim.
All right. Thank you, Roseanne. Tim, do you have any other comments that you'd like to make before we go ahead and open the floor to the discussion portion of this?
Yeah, I want to just get your thoughts regarding, obviously now once we collect that information here at NDHA, what do you see as the next steps after we collect that?
Yeah, so once that information is collected, obviously we'll review it. And then if we have areas where we can provide resources to stand up some additional critical access hospital capacity, and I'm sure that we will, that will in fact make those selections to do that and to apply those resources to develop that additional capacity. Again, just to be really transparent, if a facility has one or two additional beds that they could surge and they're able to do that with their existing staff, obviously that's ideal. That doesn't take any additional outside resource. And so, those would be things that we would want to tally up and identify. If there are areas that have multiple patients that could be surged, that's probably the most efficient way for us to use outside staffing in that environment. And so we likely would end up prioritizing those at a higher priority so that we can utilize the existing staff that is available to us on a broader basis than just one or two patients at a given facility. And so that would be kind of the analysis that we would walk through and then to begin to apply the resources so that we can build this additional capacity. All right. Tim, any other comments before we open up the floor?
I think we open it up, Tim.
All right, so let me hear from you if whatever additional questions, if we weren't clear. Again, we're not down in the weeds. We're staying at a high level with these concepts. But while we're doing this, Clint, would you bring the slide back up so that people can, in fact, see the three questions that we're asking? We're not asking for those answers during this video conference right now. We are going to be asking that you send us an email through the Hospital Association to respond to these three questions. So go ahead and unmute your microphone and make your comment or your question.
I've got a question, Tim.
Go ahead.
This is Chris Albertson from Rolla and Botno. Are we looking at any time of lowering standards of care whereby we'd be able to have CNAs or med techs pass meds? That would naturally open up and allow us to expand access and beds and capacity.
So I'm not going to say that that could never happen. Obviously, it's going to be an ongoing situation where it takes constant analysis. But as you all, I'm sure, would agree that that's not something that's taken lightly. So our first steps are to do what we're doing now to make sure that we're utilizing the resources that are available to us. And that's been the plan since we've been doing this planning for the last 16 years, that if we have to lower standards of care, that we do it in an organized fashion, that we do it statewide. And so those are the steps that we're taking, make sure we're utilizing all the resources to, as best we can, maintain the standards. And then if we find we simply don't have the capacity, and we don't have capacity that can be brought in from the outside, which is highly unlikely in the existing circumstance, then we would need to begin to lower standards of care. So, Chris, that's, it's certainly within the realm of consideration, and those steps would be taken if, in fact, it became necessary. But it's something we really do, and I think everybody hopes to avoid.
I agree. I just know it happened in Idaho, and it could happen here quickly.
Oh, that's very true. It has happened in other states. It is happening now. Thank you for that. Other questions or comments? I am going to expand just a little bit while you're developing whatever questions or comments you have on Chris's earlier question too. He specifically mentioned CNAs, and we had a end date in mind earlier on for the emergency CNA program to be ending in October. That decision has been reconsidered, and we will be making an announcement likely early next week with information about the emergency CNA program. But in a nutshell, we are going to revitalize that program and reconstitute it and not end it in October as the earlier decision had been made. We'll be reversing that, and there'll be more detail coming about that. So there will be the ability to continue to use emergency CNAs and develop new emergency CNAs as part of the process. But that's a different discussion on a different day, and there'll be written information coming out about that relatively soon. All right. Anybody have any additional questions or comments?
Tim, this is Tim at NDHA. Just a quick question regarding, when I think about licensed beds, if a CAW wants to go above that, again, we'd be limited to the number of licensed beds at this point, correct?
That's what we would see. If in fact we reached that point where that became a necessary, there's the various federal waivers, and then there would need to be the state licensure waivers that we would be doing as part of that process. That's not the stage that we're in currently. And so we're hoping to be able to maintain the existing standards of care without going to those waivers.
Chris from Nelson County Health Systems.
Go ahead, Chris.
And I was just wondering if with the referral process, is there a way to differentiate between low acuity and clinically complex patients for referrals?
So let me toss that to Roseanne if you're willing, and talk a little bit about the categorization.
Yeah, Chris, that's a great question, and that is what we're looking at right now. There are a couple of tertiary care, I believe, Minot and St. Alexis and Bismarck. There might be others too, but I know for sure that two are working on, what that triage type of categories might look like, so that, people can better make a decision whether or not they can keep them or accept a transfer, from another CAW, or, just kind of avoid maybe taking or sending that patient to one of the tertiary care. So I think that's still kind of being worked on. I know we just wanted to kind of throw it out there right now, as that is a possibility we're looking at. And one of the reasons why it caused us to even ask that in the first place is when the second call individuals from Essentia were talking about the transfers, the number of calls that they got. So for example, yesterday they had 31 within the last 24 hours. They had 31 calls from around the state, or requests from our service areas around the state for admission into another facility because they couldn't keep them or couldn't take them, whatever it was. And occasionally there are those when Essentia calls back after the second call, they call back and say, we're looking for a bed. We have some possibilities here for you. And that facility has said, well, that's okay. We don't need it anymore because the family decided to take them home. So that has happened more than once. It happens kind of regularly that there's, so that would tell you then that level of care maybe is not at a tertiary care level at this point, or maybe it's can be done through an outpatient, consulting type care service rather than an admission. So those are the kind of things that we're kind of trying to sort through. We want to make sure, once again, the whole purpose is that we get patients to the right level of care, and so that they're getting their care timely and for what they need. So there's more to come on that, Chris. I know that was a long answer to your question, but definitely working through that process.
Thanks, Chris. Thanks, Roseanne. Other questions or comments?
Tim, this is Matt down in Hettinger. The staff that you're talking about that could potentially be available from the state, is that a traveling pool, or is that a pool of North Dakota licensed individuals that the Department of Health knows something about?
It's the latter. So we have roughly 200 and, let me just do a little math here, 246 staff, half of them part-time, half of them full-time, and that they're temporary employees of ours, and they are folks that we are utilizing for a variety of missions. Right now, the priorities have been assisting with specimen collection for testing. There has been vaccination processes, and then what we call gap staffing, either in long-term care facilities or also in hospitals. And so those are the three primary missions that staff are engaged in. Thanks for that, Matt. Other questions or comments? Well, I'm not going to stop the questions at this point. I do have a couple of other things that I wanted to add to the conversation. And so I'm going to go ahead and proceed with that. But then when I'm done presenting this additional information, we'll come back to whatever additional comments or questions you may have before we close out today's conversation. And so I wanted to give a little bit more description about this EMS safety net that I've been talking about. I know that as we've seen stress within the EMS system and difficulty in terms of getting adequate workforce and the higher call volumes that are occurring within that setting as well, we are in the process of establishing a safety net that will in no way replace the existing EMS system, but will serve as an alternative if in fact the existing EMS system is not in a position to be able to provide the interfacility transfers that would be necessary to affect the redistribution of patients as we're describing here. And so what that process involves will be utilization of ambulances. Normally within the state medical cache, we have an ambulance and a process that we do this through normal emergency response activities, but we're augmenting it with additional ambulances. And so to begin with, when we're operational in this first phase, we'll have 7 ambulances. I expect this to be available next week, towards the end of the week. And then it will be staffed by North Dakota licensed EMS providers or nursing staff that will be able to effect an interfacility transfer. But again, just to be really, really clear, if any of the existing ambulance services are in a position to do these transfers, then that would be where we would be going first, and we would only be doing this with the State Health Department resource if in fact the normal EMS system would not be available. I know that we did have some difficulty in the last couple of weeks where that in fact was the case, especially involving evening transfers or night transfers. And so this is an attempt to fill that gap with this resource. I also, the final thing I want to bring to your attention, the second call system, and if you bear with me just for a moment, I will bring that up. Unfortunately, no one from Essential was able to be here because of the short notice we gave them. And so I did visit with them. They provided the slides, and so I'll just do a quick walkthrough, a review about how that process actually functions. So this state transfer center is operated by Essentia. It's really was developed at the last year in response to COVID, and it's continuing on at this point as well. And so the idea is to be able to have a process that can be done statewide that Essentia would take the lead in for acute care interfacility transfers between PPS and critical access hospitals. And the goals of this are the system serves as liaison between the hospitals and the acute transfer centers, that this facilitates a patient transfer and where possible to go to the nearest acute care facility following the normal referral patterns. But the idea again is that that's not always possible. So beyond that would be to try and keep patients within the state, if at all possible. And then to alleviate the amount of time that the hospitals are arranging these interfacility transfers during this COVID crisis. So the system is not designed for post-acute placement. So long-term care, skilled nursing facilities, rehab, and so forth are not included as part of this process. Also, regional coordination of equipment and supplies is not done through this process. And so to be clear, that remains within the state health department as the go-to entity for that. And so, Clint, if I could have you bring up the Department Operations Center emergency number, and that number is 701-328-0707, 701-328-0707. So that number is the State Health Department Emergency Operations Center. It's available 24 hours a day, 7 days a week. That is the right number to go for coordination of equipment and supplies. That's where you are able to either access the COVID response team that I spoke about earlier in terms of staffing for gap staffing. It's also the place where you would go to for any of the resources, whether those are durable medical equipment or disposable supplies or pharmaceuticals, from the state medical cache. And so please don't hesitate to call that number for that regional coordination of equipment and supplies and staff, or any other need that you end up needing assistance with, and we're there to help, and we'll, if it's not something that's within our resources, then we'll direct you to where we believe those resources may exist. All right, so this just quickly walks through what the existing process is. So we start with the transfer need identified by the critical access hospital or the PPS hospital. And then once that need's identified, then the CAH or the PPS contacts their normal referral PPS. So that part is the same as it is outside of COVID or any other, or during normal operations. Then if the PPS hospital is unable to accept the patient, now we go down through this other process where the critical access hospital or PPS contacts the North Dakota State Transfer Center for assistance. Those are the folks at Essentia. And they began making phone calls to the other PPS hospitals across the state to find bed placement. And then once that is accepted by the PPS for the interfacility transfer, the patient's then transferred. So that's the normal decision protocol. So going all the way back up to the top, if the critical access hospital or the PPS makes contact with their normal referral PPS and it's accepted by that PPS, well, then that process just stops, and that transfer then is accomplished. And as I previously said, if Essentia needs additional assistance, they reach out to the Department Operations Center, and we assist with this process as well. So, in order to affect that, there's a phone number, and I'll cover that in just a moment, that I'll be sharing with you. But the State Transfer Center shares these activities on a daily report that comes into the conversation that we have daily at the state level between the PPS hospitals and the state representatives, and that happens every day. So we have situational awareness about what's actually occurring with that. And then the phone number that I was alluding to, and that's 833-594-0373. 833-594-0373. So that number is also available 24 hours a day, 7 days a week for this system that's called the Second Call system. There's also the email address for the Second Call system that's displayed on the screen. And so I'm just going to leave that up for a little bit so that you have the opportunity to see that. All right, that is the information that we had prepared for you today. I'm going to ask you to, once again, if you've thought of some additional questions or have additional comments, to go ahead and open your microphone and state your question or comment.
Eric and Ashley.
Go ahead.
I know we did this last year during the outbreak, but what allows us to access the CNA nursing pool? For instance, we have an outbreak in our community, not necessarily in our facility, but everybody is having to take off to go care for their family members, basically, or are in the quarantine process. How do we access that pool again?
So it's the same answer, Eric, thank you for the great question, regardless of the staffing need. And that would be to contact the State Health Department Emergency Operations Center at 328-0707. So just dial that up, discuss the need, and we would be happy to assist with whatever resources that we have available.
Okay. And then one other comment more than anything would be a lot of times these ambulances are deadheading back home empty, going through another community. If that is part of your plan, there's possibility that there's another route for somebody to transfer somebody for you out of these bigger facilities?
Yeah, and to be really blunt, that's exactly what we do. When we have encountered these situations in the past, we note who's actually on the road and have actually rerouted ambulances, or at least checked on the availability of them to be able to reroute and pick up another patient. And frankly, we're not at all shy about this. We've even asked ambulances to go to a different location than returning back to their home base, but because they were within the vicinity. So we try to manage those assets as efficiently as we can.
Okay, thank you.
Thanks. Other questions or comments?
Tim, this just really, oh, I'm sorry, go ahead.
There's some comments in the chat box I've noticed.
All right. Tim, are you in a position where you can see the chat box?
Let me take a look here. Yeah, I think the first question or the first comment is, and I'll just read it off for you, Tim. Social determinants of health and payer issues tend to be some of the reasons we see low acuity patients staying in the hospital. These types of patients were sent to cause. Would the Department of Health have any support options available to assist cause with payment for taking these patients or placement assistance after hospitalization?
So the short answer is I don't know. What we've attempted to do in the past when we've encountered similar situations and other emergencies is to try and see if we can get them qualified for other programs through human services. I would assume that would be kind of our first go-to to see what other programs we can get folks enrolled in. But we would certainly work it as an issue and try and identify if there would be any resources that we would be able to bring to bear to help resolve that.
Okay, yeah, great question by Melissa. And I think Eric had one, but I think
I just asked it. Don't worry about it.
And then Marcus Lewis is asking, are these extra EMS resources staged across the state?
The initial establishment in this very first phase, all of those ambulances will be located in the Bismarck area. So the direct answer is no. If in fact depending on the severity, if the judgment is made that we don't have sufficient resources, it's possible that we could stage additional ambulances in additional locations. But at this point, it makes the most sense to us to keep the ambulance vehicles in the location where the majority of our staffing actually exists. And so that's why they're staying at this first phase of 7 ambulances within the Bismarck Mandan area.
Tim, that takes care of everything in the chat box room.
All right. Well, it seems like we may have exhausted whatever questions or comments that we may have. And let me first go to the VP3 team and see if anybody there has any closing comments.
Tim, I just got a text from Roseanne. She had to leave the call.
All right. Well, that took care of that.
Yeah.
And so let me see, Tim, if you have any additional comments.
Just a comment, I saw today we had roughly about 90 participants. So that's awesome. I mean, that's great to see. So I think, Tim, just one request that I have, if I could get, I think that slide that contained those 3 questions, and I'll send that out as just a reminder to my members.
Excellent.
Yeah.
All right. Let me also close with a couple of things. One is that I know that as we've had this conversation, we're trying to rely on and are relying on many of the things that we have established in the last 16, 18 years as part of the hospital preparedness program and the emergency response work that we've been doing across the state through the Hospital Association as a partner, through the various hospitals as well. And so many of those infrastructures are serving us very well. I want to just draw your attention, if in fact you do need additional medical supplies, whether that's disposable medical supplies, pharmaceuticals, durable medical equipment, don't hesitate to go to the North Dakota State Medical Cache, and this is what that site looks like when you go there, and it's at honassets.nd.gov. And don't be shy if you have items that you're not able to acquire through your normal mechanisms from your normal suppliers. We're able to, and if we have it, we'll be able to provide those to you under these emergency circumstances to keep you up and running. And then please, if you are inclined, and we are asking you to seriously consider building additional capacity within the system, if it's any equipment need or supply need that we can assist with, please don't be shy about acquiring those equipment pieces or the supplies from this site as well. And then if it's staffing, then please contact us at the phone number that we previously provided for the Emergency Operations Center at 328-0707. I think by building additional capacity within the critical access hospitals, we can help decompress some of the pressure points that we're feeling, and that would be a very valuable asset for us to have as we then can provide appropriate levels of care in settings without having people waiting excessive periods of time to acquire the necessary hospital beds. Thank you so much for your time and attention. We will be having our regular meeting, and that's the fourth Wednesday of the month. And so hopefully at that point we'll have information that we can come back and share some of the results that we have from the work that's been done here, and continue to keep you informed about the steps that we're taking regarding the additional capacity that we're attempting to build through these processes. Our programs are archived, so if there's somebody that wants to see this, we will have this in with our regular archive at www.ndhealth.gov/ET. Well, thanks for your time and attention and all the good work you're doing. Tim, you have another comment?
Yeah, sorry. I just want to just say thank you. Appreciate all the work that you and your team are doing in terms of coordinating these types of calls and working with all my members. And so again, just a appreciation to you and your team.
Well, and it is a team, and it takes all hands on deck, and we're pleased to be part of that team. Thanks, everybody.